Okay, panelists, more than welcome to have you join me.
Dr. Meichenbaum, can you hear me?
Yes, I can, Bruce. Thank you.
Well, I guess I would like you to comment a little bit more on complex PTSD. You kind of referenced it in passing. I'm hearing it not so much in the literature, but more just kind of thrown around in social media and that sort of thing. People saying they have complex PTSD and kind of wondering what your thoughts are on that, and maybe as an additional question, kind of like almost where trauma starts to become an identity, right? Like where
Right,
my trauma becomes who I am, not what I'm working toward growing through.
right. So I mentioned at the outset the work by Judy Herman, the psychiatrist, and she has been an advocate of the concept of complex PTSD. In fact, the international classification have now included CPTSD as part of their diagnostic category. And one of the things is that the complex kind of thing is where there's repeated victimization, either due to the cumulative exposure to complex adverse childhood experiences, or for instance, our work that we're currently involved in with spouse abuse or domestic violence or other forms of victimization. My understanding is that when you have that kind of cumulative impact, the nature of the symptomatology, the nature of the problematic behavior is more varied. It's more personological in nature. It has to do more with core beliefs, what you characterize as part of the identity that develops in that fashion. There's a high likelihood of re-victimization that needs to be addressed therapeutically. There also has to deal with the whole variety of problems with regard to self-injurious behavior and the like. I can go on about the variety of symptomatology. So I think we need to recognize as therapists that there are different forms of trauma. There's the sort of one-shot thing, where there was, a rape or some kind of robbery or accident or social climate, a tornado came in. But when these kinds of events are cumulative, then I think that there's some merit for us to think of complex PTSD. That's my first response. The second kind of thing about the identity is you, the therapist, have in fact identified some kind of behavioral pattern, and when my sense is to go public with the data. By that, I mean that you, the therapist, should say, I noticed something. I wondered if you noticed it too, to the patient. And I get the impression, correct me if I'm wrong, see if I picked up on, see if I'm in tune with this kind of psychological curiosity that gets conveyed, that at times I feel that you have experienced so much hurt in your life. How should I say it? That all of that hurt has taken a toll on you. And in some sense, I'm not sure of the exact words here, but it's become part of how you see yourself, your identity. Okay. So what I'm modeling for you is how I would respond.
Right.
Okay.
Yes.
So I'm going to go public with the data, and use my psychological inquisitiveness. Try empathy and say, I can well understand that you would come to do this. Okay. I'm going to validate and normalize this reaction. But my concern is, what is the impact? What is the toll? What is the price? And if this was not your identity, how would life be different? Okay. I'm not sure if I'm getting close to your concern on those two issues.
Yes, you are. Thank you very much. I appreciate that. It does seem like that kind of empathic approach does allow that person to start to step back and observe the fact that this might become an identity and possibly even that they have another option, right?
Yeah, and therefore you're wondering how the two of us, you and the patient, could help understand what is the impact, what's the toll, what is the price your client is having as a result of that. And moreover, what would it take for the two of us to move beyond it? It's going to take a lot of courage. It's going to take a lot of challenge. I'm not even sure we'll get there. Okay. I mean, that kind of, self-efficacy training becomes an important element. But when in doubt, go public with the data.
Mhm. Yeah.
Do it in a kind of inquisitive fashion. I was always a fan of the TV personage of Peter Falk playing Columbo.
Mhm.
Remember, that
Yeah.
TV personage,
Mhm.
of him using his curiosity, using the art of questioning.
Right.
I'll tell you what you should do, Bruce. Play dumb. It won't be that difficult. It will come naturally, not only to you, but to
Yeah, it
others.
just comes right out. I understand that.
That's why you're here.
Yeah.
Okay, other panelists.
Thank you.
Yeah, please.
Yes,
Yes, George.
Dr. Mike and Mom, I'm struck by some of the basic things that you said, or I should say the basic cores of therapy. Things that I, were exposed to way back in graduate school, that the alliance is most important, that we can get as techniquey as we want, but that's of no value unless we have engaged with the other person. I remember one time in graduate school, I was working as a psychiatric technician at the time and had some experience with hardcore psychosis. And one of my classmates said, "Well, what do you do if someone starts crying?" I said, give them a tissue.
Right. You should never do therapy without having a box of tissues in your room.
Yes.
That's kind of thing. And essentially, Carl Rogers lives. Whatever you learned back then is still applicable right now.